My topic is calcaneum fracture, and it is a so big topic. It is not possible to cover up all these things within the 10 minutes, but I am trying to concise as much as possible for the PG. So, calcaneum fracture basically the 2% of all fractures, 60 to 75% are interarticular fracture, 10% have associated spine injury, 26% have other extremity injury, and 90% occurs in young age group. That means from 20 to 45 age. Uh, Here I share a picture. This is a historical picture where Cotton and Williams initially do this treatment. They recommended that close treatment with use of medially placed sandbag, a laterally placed felt bag, and a hammer to reduce the lateral wall and re-impact the fracture. So this is the historical treatment which was started uh, by Cotton and Wilson during the early 90s. And from there, the latest trend is right now. So basic anatomy, there is a superior or axial anatomy of the calcaneus, as we know. Also, if we corresponding this superior anatomy with the axial view of the city, we just got this kind of picture during our city. Schematic diagram of the calcaneum at more proximal posterior facet level compared with the city level, the same level. So this is the medial malleolus of tibia, this is the lateral malleolus, here is the talus, and posterior facet of the calcaneus with subtubular space and body of the calcaneus as a whole. So this is the schematic structure which is corresponding with the city. There is another X-ray picture where we can see the some traction trabeculi and compression trabeculi. This is the basic thing which we need to treat a calcaneum fracture. And also there is a neutral triangle which is very essential to assess the pattern or whether is there any fracture in the calcaneus. There is a thalamic portion also, and also this portion when we discuss in our case, we also discuss that how we put the thalamic screw to fix this thalamic portion. Volar angle is normally 20 to 40 degrees. Already it is said in his radiological part. This is a fit, and another angle is critical angle of this. So here is another anatomical structure of the calcaneus with the superior surface. There is 4 articulating surface, 3 superior and 1 anterior. Superior surface articulate with the talus, posterior facet, middle calcaneal facet, and anterior calcaneal facet. The triangular anterior surface of the calcaneus articulate with the cuboid. So here is another medial surface. You see lateral surface, flat, subcutaneous. Here is the peroneal tubercle, the attachment of the calcaneofibular ligament centrally, and lateral talocalcaneal ligament attached anterosuperiorly of the peroneal. So, mechanism of injury. Basically, it is a high energy motor vehicle accident or fall from a height. Lateral process of talus act as a wedge, and there is also impaction factor. So, here is some clinical feature which present to us after a calcaneum fracture. Pain, swelling, not able to bear weight. On examination, we get marked swelling, ecchymosis, blister, tenderness, very much tenderness. Movement is restricted. Other foot and spine should be examined during this period because we know that during the calcaneum fracture, there is always sometimes associated with the spine fracture also. Compartment syndrome should be ruled out. Sometimes 10 to 15% of calcaneum fracture are open fracture. Here is some another clinical feature. Note the condition of the skin. It is very much essential. When there is whether it is an open fracture or fracture blister, and there is always a credence skin where there is a avulsion fracture of the posterior part, and that displaced fracture fragment doing this bruise over the insertion of the Achilles. And also we should examine the neurovascular system. So here is a classification, broad classification, intra-articular, this is by Essex, Lopresti classification, extra-articular, there is 25 to 30% in the fracture, anterior process fracture, mid-calcaneum fracture, where the body, sustentacular tali, peroneal tubercle, lateral process may be fractured, and posterior calcaneum fracture, obviously the posterior tuberosity may be fractured, and it is called the extra-articular. This is basically based on the Sanders classification also. So assessment is very important. Radiological assessment as well as clinical assessment is very important during taking the decision. In our PG life, we always go through this kind of calcaneum fracture, whether we do the operation or not. So it is very important to take the decision. The radiographic assessment begins with the 3-view foot and as well as an axial Harris view. The basic fracture type, that is tongue type versus joint depression type, are best demonstrated in the lateral view. So here is the basic radiology. Already we have discussed the Wohler's angle, normal 20 to 40, Gissen's angle, and it is disrupted during the calcaneum fracture. So nowadays we always go with the CT scan to make our decision in a right pathway. So there is axial cut, coronal CT scan, as well as sagittal CT scan. We should go all this cut to take our decision. Surgeon must consider the patient as well as the fracture when making the decision about the treatment. So decision making for non-operative management, first patient consideration with minimal articular involvement, with adequate maintenance of heel anatomy, with medical contraindication to operative care. Fracture consideration, less than 2 mm displacement of articular surface, we can go with conservative. No gross varus or valgus malalignment of hindfoot, we go with conservative. Here is very important to assess the soft tissue condition. All heel fractures have a spectrum of soft tissue injury. This is very important. And RICE therapy is essential. Non-weight bearing is essential until the final treatment plan. Soft tissue consideration, the amount of swelling is a good indicator of the degree of soft tissue injury. Wrinkling sign of the skin is very much needed before doing any surgical intervention. And we can delay our surgery till the 8 to 14 days, maximum to 3 weeks in a case of calcaneum fracture. So, non-operative treatment, continue patient compliance with smoking cessation, elevation of limb with range of motion, posterior spleen, weight bearing is not allowed except toe touch for 6 weeks, and radiographic follow-up at 6 weeks and 12 weeks is advised. When we get the open fracture,
2 more minutes, Abhijit.
Surgical emergencies need urgent debridement and bony fragment reduction with temporary fixation. Percutaneous work sometimes we fix to hold the bony fragment. Like this, here is some percutaneous fixation initial, then we put some Elizarov ring fixator in open comminuted injury. When to operate, there is no general consensus on the indication for surgical treatment of calcaneum fracture. Depends on case-to-case basis. Timing of surgery, it is definitely percutaneous fixation if we plan for within 7 days. Otherwise, osteosynthesis, we can wait till the 3rd week. Primary fusion in comminuted fracture, highly comminuted Sanders type 4, we go initially, but the recent study shows that it is reasonable to perform ORIP or on patient with Sanders type 4 fracture and perform secondary arthrodesis only if painful subtalar arthritis develops. So take home message, an individualized treatment approach and precise preoperative planning, open fractures and closed fractures with compartment syndrome or severe soft tissue increase the chance of more problem. Non-displaced, mildly displaced extra-articular fracture intra-articular fracture with step-up of less than 2 millimeter, and patient with general contraindication of surgeries like coronary artery disease, uncontrolled diabetes, heavy smokers are treated non-operatively. Once again, I request everyone to come and join our 33rd IFASCON, which will be held in Calcutta, 26th to 29th August 2021. The concept is evolving concept in foot and ankle surgery. Thank you, everyone.
So you are mute. So you are mute.
Sorry. Thank you, Abhijit. And now I would